Sure.
Okay. So good morning, everyone out there. My name is Tony Newman. I'm serving as the acting director for the Division of Senior and Disability Services here at the Department of Health in Alaska. And I'm coming to you from Juneau. And I'm here with some colleagues from Senior and Disability Services. We're going to make a short presentation. I'll introduce those folks as we get to their pieces of this. But I wanted to stop and give particular thanks to Steve Lutsky and Andrew Sislinski from HCBS Strategies for their help putting this presentation together, as well as in the larger project. So why don't we go ahead to the next slide. This is a stakeholder engagement session, and this is going to be our agenda today. First, we'll talk about the legislature's request to us. We will talk about the current intellectual and developmental disabilities waitlist, how it currently exists. We'll talk about two possible approaches to the legislature's request and some of the challenges and questions that we would have about those challenges, and talk about next steps as well, hopefully leaving plenty of time for questions and conversation. And the next slide just talks about how we're going to format this webinar. There's a Q&A button at the bottom of your screen. Hopefully you can see it. If you don't, just hover your cursor down low on your screen. You can ask questions in the Q&A. You can also raise your hand, use the raise hand icon under, you see raise hand there at the bottom, if you would like to be unmuted and ask your question verbally or make a comment directly. We are seeking input on on what we've proposed here and any other ideas you may have. And we do plan additional sessions as we work up a draft plan and pursue some fiscal impact estimates. We haven't scheduled those other sessions yet, but they will happen over the next several weeks in time to allow for a submission of a plan to the legislature by December 20th. Steve or Andrew, is there anything else you want to add about sort of housekeeping?
Nope. Just to encourage you to use the Q&A rather than the chat, just because it's easier for us to record things from the Q&A. And we want to make sure we have a record of everybody's input.
Okay. Okay, thanks. So to get started here, this is why we're holding this session today. This is why we're meeting. In the operating budget bill that passed the House and the Senate this year, this language was included. It said that it is the intent of the legislature that the department develop a 5-year plan in collaboration with stakeholders to eradicate the wait list for the intellectual and developmental disabilities waiver and to prevent wait lists for other home and community-based waivers, and submit the plan to the co-chairs of the finance committees and the Legislative Finance Division by December 20th, 2022. I want to point out that this intent language that was in the budget bill didn't come with any funding to help the division put this plan together. And because we have so much work on our plates already and limited funding to even do that work, we reached out to the Mental Health Trust to see if they would support us in meeting this legislative intent language. The trust agreed. They agreed to fund a contractor. That's Steve and Andrew of HCBS Strategies. And they are helping us do the detailed work that would be needed to realize this. Steve Lutsky has worked with us on many projects. He knows Alaska well. He knows also the landscape of HCBS services around the country. So we're pleased as always to be working with Steve. If you are interested in seeing this language firsthand, it's in HB 281, and you can see it on page 22 of that bill. Okay, next slide. And here I'm going to turn it over to Pam Kellish, who is the Chief of Developmental Programs here at Senior and Disability Services and is coming to us from Fairbanks. Go ahead, Pam.
Yeah, thanks, Tony. Good morning, everyone. So on these next two slides, I'm going to talk a little bit about the current waitlist process and what that looks like to set the foundation for what the proposed changes are that we're making. As you know, the department is required to maintain a wait list of persons who experience developmental disabilities and also meet the level of criteria in order to be eligible to receive home and community-based services. CMS, the Centers for Medicaid Services, has approved the use of a wait list to manage to manage the two waivers, which is the individuals with intellectual and developmental disabilities waiver, or the IDD waiver, and also the ISW waiver, which stands for individualized supports waiver. The ISW waiver does not currently have a wait list, as the program is not at capacity, although it is nearing capacity. So the current wait list currently has about 440 individuals waiting to receive services. Of course, this changes monthly, depending on how many people submit to be on the wait list, as well as how many people have been drawn, excuse me, have been drawn off of the wait list to receive services through the waiver that month. Excuse me. The average wait list time is 4.5 years at this time. However, that does vary widely depending on the criticality of the person's needs. So those that have very emergent needs may only wait a few months or even less. The process can be accessed at that link there. And Steve, if you could maybe click on that link. I'll explain a little bit about it. Once an individual has been determined to have an intellectual developmental disability by submitting an applicable medical, psychological, or other qualifying documentation, the individual works with a DDRC, which is a Developmental Disability Resource Center representative, who is there to help the person through the process. The DDRC rep will fill out the DDRR, which is the Developmental Disabilities Registration and Review Form, to help them get on the wait list. And that form can be found on this webpage. Yep, right there. The form has 14 questions, and then it's submitted through the Harmony database system. The questions on the form are there to measure the immediate needs and circumstances of everyone on the registry, and it's used to weigh those needs against the needs of all applicants. At that point, a QIDP, qualified intellectual disability professional within SDS, reviews the form and adjusts the scores based on the narrative provided. The Harmony system tabulates the score and places them on the registry in score order. To remain on the wait list, the individual and/or his or her family must submit an updated DDRR form every year. To be selected from the wait list, a select number of people are drawn monthly. At the top highest numbers drawn first, and then according to how many can be accommodated, and also per legislative mandate. And as far as annual reports, they can be found at the link listed there. An annual report to the governor and the specified legislative committees must be presented when there's not adequate funding to meet the needs of all individuals determined to have a developmental disability and meet the level of care for services. This report includes information on the waitlist process, the needs, preferences, and estimated costs to serve individuals on the registry or the waitlist, and the number of individuals selected in the fiscal year, as well as the number of individuals on the registry for more than 90 days, among other information. The next slide. So this slide talks about the annual report to the legislature on the wait list in more detail. The cost estimates are based on information that's received from that DDRR form that I talked about, and what types of services and needs the individuals on the wait list are expressing they need to help them be in the least restrictive, most inclusive settings for home, work, and other areas of their life. It's important to note that the minimum requirements that CMS requires. For example, we are required to have a level of care process, whatever approach we take. We have to show that the individual would otherwise meet the institutional level of care in order to receive any health and community-based services. CMS, Centers for Medicaid Services, has authorized our use of a wait list with both the IDD waiver and the ISW waivers. So it is allowable through both waivers as needed. The estimated cost of $37 million is current state federal funding alone and does not include the federal Medicaid match of 50%, which would bring the total cost to approximately $74 million a year with both the state and federal funding included. And now I will turn it back over to Tony.
Pam, thank you. Okay, so just to recap, the legislature asked for a plan to basically get rid of the waitlist process that Pam has just described. They just asked for a plan. They didn't give us any more detail than that. So as we've talked about their request, our thinking in talking with Steve and Andrew and leadership here at Senior Disability Services is that we actually provide them with two plans, two approaches to eliminating the wait list. And we thought first we could eliminate the wait list by providing funding for all needed services. We could take that simple of an approach suggested here by the sledgehammer and simply tell the legislature that we need to put the resources behind getting rid of the wait list. Or we could take a more refined approach suggested here by the surgical instruments that does eliminate the wait list by using resources more efficiently and also helps SDS and our stakeholders in a way that better reflects our beneficiaries' needs, strengths, and choices. So what we want to do now is lay out these two potential approaches for you and hear your thoughts and get your comments on these approaches and hear whether you think this plan for our report to the legislature has merit or if there's other ideas that you would suggest. Okay, so to the next slide, let's talk about that first approach, the sledgehammer approach. This would mean that we simply tell the legislature our estimate of what it would cost to basically keep the existing application and level of care assessment and review process the way they are now, and inform the legislature what it would cost to provide the services to all the individuals waiting, both those on the wait list actually now and those not yet on the registry, whom we might not even know about at this point. Now, as Pam described, based on our FY21 numbers, we had 772 individuals on the wait list as of June 30th, 2021. The blunt calculation to serve them, as Pam mentioned, based on their self-reported needs, was put at $37 million in state funds, or a combined federal general fund total of $74 million. The plan to the legislature not only required us to eliminate the existing wait list, but also prevent the creation of any new wait lists. So as Pam mentioned, the only other waiver besides the IDD waiver that approaches having a wait list is the individualized supports waiver, which has a cap on the number of people who can participate. That cap is 600, and we are approaching that number probably within a year or so. So any plan would have to address both waivers and ensure we're not allowing any wait list. Next slide. If we take that approach, we still know that this simple approach would result in some questions and challenges that would need to be addressed. So for example, how do we accurately estimate the number of people who may meet the IDD level of care eligibility criteria who are not on the wait list now? And what would their costs be? That's sometimes referred to as the woodwork effect. Who would come out of the woodwork that we don't know about? Based on some projections, thousands of people could meet level of care in Alaska, but have elected not to apply or try to get on the wait list. If there are indeed thousands of people who fit this description, it could cost on the order of $820 million per year to serve all of those people who may meet IDD level of care criteria at current average costs per person. So that's one thing we'd be interested to hear your thoughts about is are there people out there who are not applying now who we would have to take into consideration? Thoughts about that? Second, what mechanisms could we include that will lower overall costs? That is, could we include or mention in the plan approaches that could mitigate the sticker shock of trying to serve so many people all at once? And that led us to the second approach, represented by the surgical instruments that we're going to talk about in just a moment. And finally, provider capacity is an important consideration no matter what approaches are taken. It would do little good to eliminate the wait list if the services that the people need aren't there for them to start with. So how do we ensure provider capacity is present to take on the influx of recipients, including the behaviorally and medically complex individuals? Okay, well, that's a very high level overview of the first approach we could take to eliminating the wait list. And now I'm going to turn it over to our acting deputy director, Lynn Kyleman Cruz, to talk about our second more surgical plan that we could provide to the legislature. So go ahead, Lynn.
Thanks, Tony. One of the things that we have talked about is in the past has been the inter-eye assessment tool. So some of you may remember that years ago, I think around 2016, 2017, we contracted through a contractor, I think it was HMA, and we conducted a review of all of the assessment instruments. The researchers worked with various stakeholders and SDS, and we determined that the inter-eye assessment suite made the most sense for eligibility and service planning. SDS has done work to further explore that tool, but because of other priorities has not been able to fully implement it yet. COVID being a large part of that. The stakeholders and SDS are most interested in inter-eye because it demonstrated a track record for inter-rater reliability through standardized training and application. So the inter-rater reliability means that every assessor applies the tool in the same way. And it comes with very standardized training kit to be able to do that, which is always good. It's also used in a variety of states, has a suite of tools that could fit several of our, or all of our waivers. And so it just, given the pros and cons of every type of tool, there's no perfect tool. The stakeholders through this contractor and SDS came up with the thought that inter-eye would be the best option. So to be able to apply a resource allocation, and what I mean by resource allocation is assigning service levels based on needs that are identified through the assessment process that allow for, assigning service levels will allow for a better predictability of budgets and more flexibility among service choices. And eventually more control and direction from the individuals we serve. So it would not be done lightly, and it would require a good baseline set of data from the assessments before we could even begin the work. So we would have to have a few years to gather data, go back and forth with stakeholders and plan for what the service levels would look like. And of course, as Tony mentioned, I think before, we would want to do all of that without causing people harm or undue harm or effects from the planning, from being able to fit inside of a budget. I'll try to explain that a little bit more in the upcoming slides. Can you go to the next slide, please, Steve? Thanks. So resource allocation, this pyramid is does not indicate the level of need, but more of how the population we serve falls into groups. This is what we believe based on some other studies and the work that Steve and Andrew have been doing. The largest tier at the bottom represents the majority of people that actually have less needs. They're less complex. That fits a lot of the population. The smallest tier at the top represents the folks that have the greatest needs and would therefore utilize more services. So this is not like how services would be allocated. This is where the population sort of rests. Resource allocation would consider an individual's level of need and then carve out a budget based on that level of need. Again, it's something that would take time and thoughtful analysis, so it wouldn't be fast. Thus, the 5-year plan, we think we could do this in 5 years. We would, of course, as Tony mentioned, this is just a high level overview of sort of the options that might be available to us. But all through the process of those 5 years, if the plan were to be supported, we would require a lot of feedback and interaction with folks and with contractors smarter than me, than us, maybe. Next slide, Steve. So if we were to adopt a resource allocation approach and try to develop budgets or tiers, how would it impact the people we're serving now? That's a very good question. Like I said, we would not want to cause folks to lose services or be put into a tier that would harm them in some way. So we would have to be very careful and thoughtful about that process. And how do we handle outliers, people that need more resources or more services than the resource allocation tool suggests? Those are all something that during the data gathering and the review, we would really look at those. Some of you participated in or were part of what we called an acuity sort of study we did before. And we had to very carefully work through where we thought people were based on their assessment and how and what tier they might have fallen into. Unfortunately, we couldn't go forward with that work either. But we're hopeful that, the time is ripe and that we could make a plan for going forward for this. We know also that it will take several years and require a number of steps. Like I said, we want to do it thoughtfully. We don't want to rush through it. And then how should we use resource allocation to increase flexibility and self-direction for recipients? There's a whole different schools of thought on that. And we would want to hear from everybody. So we would obviously need to have a lot of engagement with all of you. We know this isn't an easy task, but it is something we believe needs to happen for us to move towards a real and meaningful change towards a person-directed program. So I think we've heard loud and clear from folks that that's what our stakeholders want. And so this is sort of our attempt at trying to develop a plan to inch us towards that end goal. Next slide, Steve. And I think I'm turning it over to Tony for this.
Yeah, thanks, Lynn. This kind of rehashes what you've just said, that this is the legislature has asked to see a 5-year plan for implementation. So it can be a years-long project. We can tell them how we can do this right over the course of several years, not something that would happen right away. And that's another point that bears emphasizing. Their request is only for a plan. It's not a commitment to fund the plan or make anything in the plan happen. The legislature that made this request for a plan and is coming to an end with the election in November can't obligate a future legislature or administration to spend money on the plan. All they've been able to do is ask for a plan. So, but if someone in the legislature or the administration likes one of the ideas in the plan and wants to make it happen, what they would then need to do is develop a bill, develop the fiscal notes that go along with the bill, get it through the legislative process and get it through the governor's signature. So since this plan would be in their hands by December 20th, it's possible that someone could develop a bill in time for the session beginning in January or fit funding for a realization of the plan into the budget by the end of the legislative session that'll begin in January. So just wanted to temper some of the expectations that this is simply a request for a plan, nothing that we end up writing down and provide to them is assured of passage or actually happening. So next slide. Oh yeah, where do we go from here? From here, we'll be working with HCBS strategies. And our intention, as I mentioned earlier, is to return to you with at least 1 or 2 additional sessions to talk about the modeling that would need to be done on numbers of recipients, amounts of services, fiscal impacts. Our goal is to have a draft plan to present to all of you, our stakeholders, with plenty of time before December 20th, so we can consider and incorporate any feedback you may have. So stay tuned for those additional sessions. We haven't scheduled them yet, but we do have Stephen Andrews' email address there, idd@hcbs.info, where questions and comments and concerns can be emailed to them if a question or thought occurs to you and you don't get a chance to ask it here. So, okay, so that's our short presentation. We still have plenty of time together though. So, Steve, I think I'm going to let you sort of let me know what the Q&A says or the chat.
Okay. There were a number of comments talking about challenges with provider availability, and a number of them attributed that to challenges with rates, with existing rates, being able to find service providers. So they were wondering if there was any efforts to revisit the rates.
Well, as many folks know, we're in the middle of a rate rebasing that's underway right now, and we have just managed to get the legislature's 10% increase out there, and those rates are now in effect. Whether or not the plan needs to include any mention of the state of rates is something that we'll have to consider working into the plan, and whether an increase in rates would be necessary. I think that's your expectation, Steve, that will be at least something that will get some acknowledgement and mention as you work along.
Yes, it will.
Okay.
Okay. There was one comment asking if there could be a research or study on cost savings that might result by paying for services earlier, because that might be preventing hospitalizations and other costs that happen when people end up within a crisis because they don't have existing services.
I can take that one if you want,
please.
Tony.
Sure.
I was just thinking about that particular question, that this would be one tool. So when you think about the folks with individual needs, if they felt, say for instance, an example, they had very little need when they came into the waiver, and they were being met by that lowest band of tier. If they started experiencing higher level need, that may be something that we would have a method or a mechanism for them to apply for that higher level of need, so to prevent an institutionalization. Perhaps maybe they need behavioral supports and it would cost more. That might be an amendment to existing services, and it may end up being able to help in those situations a little bit more flexibly than we are able to at this point.
Yeah, thanks, Lynn. And Steve, I'm curious, in your work with other states, have you seen that they have that sort of flexibility built into their systems?
They potentially would have some ability to start to serve people, based on if they're triggering because they have some sort of a crisis or some sort of another event. As far as factoring it in terms of cost savings, that would be difficult. I haven't seen any studies that specifically address that, but if anybody knows of any that they want to send to us, we would certainly be happy to look at them.
Okay. What else have people asked, Steve?
Okay. Anna was asking what would happen if you have more high needs people than what is carved out in the budget. So like what would happen if we project a budget, they pass the plan, and then the actual costs are significantly higher than what was budgeted.
Well, I can tell you big picture wise, that when that happens in state government, generally you have to go back and ask for a supplemental when you overcommit the state to funding more than you have been authorized to spend. But I think you're asking more about what kind of mechanisms would be in place in the resource allocation method. Lynn, you kind of answered that question as previously, but did you have anything you wanted to add?
No, I don't think so. I mean, I think you just said it again, so.
Okay.
Okay. Then there was, Anna was asking, can we act in concert with a pilot program for certification of DSPs?
Well, to that, I would say that we, and as you probably know, we do have a pilot project for certification of DSPs already underway. We are eager to see how that unfolds over the next year, 2 years or so. I'm not sure how this effort would act in concert with our waitlist elimination plan, but certainly we'll give that some thought as we go along. We certainly recognize that the provider capacity needs to be there, and that professionalizing and offering certification for DSPs is something that a lot of people would like to see, under the expectation that that could enhance recruitment and retention for people in that field. So we certainly are eager to see how this pilot project already underway contributes to that, to people's longevity and retention in the field.
Okay. And Ken was asking about, he was talking about the workforce issues that others had raised, but he was asking specifically, is there a way to compensate families to keep family members at home and care for them?
You know, I'll say I first of all, I appreciate the comment that Ken makes there. The sledgehammer plan is DOA just fiscally. I mean, that was part of the reasoning why we thought we need more than just telling the legislature that we may need several hundreds of millions of dollars to make this happen. We thought, what's a way we can reduce the sticker shock, which is why we came up with sort of 2 approaches that the legislature could consider. Workforce issues and compensation for families. That's something we're hearing more and more about. You may know, Ken, that the legislature actually had a bill out that begged that question. It's something that we're talking about a lot more. We would want to do it safely and make sure that we're doing our best to prevent any enhanced abilities for fraud or abuse that could occur. But apparently some states are doing it. And we're eager to learn more about that as the next months proceed. So I'm not going to commit to any answer there, but just to assure you that we're aware of that, and we recognize that as you say, it could indeed be a big help to keep people where they're most comfortable and help meet the provider capacity issues. Let my team respond if they have anything they want to add to that.
I think you covered it well, Tony. Thanks. I don't have anything to add.
Okay, Jacqueline, and we may want to ask her for a clarification, but she asked, are you planning to use 638 tribal claims as part of these approaches?
Yeah, I don't know how to respond to that. If she's speaking to tribal claiming, then yes, I mean, that's already a part of our Medicaid services, and it means that for particular people, for particular Alaska Natives who go through the right referral process, they can receive 100% federal reimbursement. That's in existence now and would continue to be continue to be the case.
We can receive reimbursement, not
right.
them.
That's right.
And
thanks, Jetta.
Jacqueline, if you wanted to clarify anything on that I've allowed you, you can unmute yourself and ask the question directly. Okay. And Noel has his hand up, so I will allow him to talk. Oh, did we lose him? And I think he must have pressed the wrong button because he disappeared from my screen. Okay. Heidi was asking, does the InterRide tool have tracking abilities for effective interventions? Also, we looked at paying family provider being a permanent accommodation, since that was one of the only ways our clients in rural areas can receive services.
I can answer the InterEye tool, perhaps in part. So the InterEye tool is really a suite of tools. It's a whole bunch of tools that the University of Michigan and several other universities put together. And I think Steve put this resource in the chat for you guys to go and look at that if you wanted to, or he answered that question. But essentially, there's a core set of elements that are in every tool. And so potentially, if you used it through the screening process, through the assessment process, even in a long-term care facility, you may be able to tell if someone could need some type of intervention earlier rather than later. So there are algorithms that you can set up within the tools, as long as you have the whole suite engaged. But that would take some time for us to be able to do that. And I don't see that happening right away. But it is a possibility with InterEye. And if you go to the website, you could learn more about that. Also, the second part of the question, have we looked at paying family providers being a permanent accommodation, since that's the only way many of our clients in rural areas are receiving services? Yes, we are reviewing that. We have looked at that. In some of our services, we do allow for that. It's just a matter of what the federal government allows and how we might implement that here. So it is something that we are considering.
Okay, and Carly had commented about the staffing and the cost for staffs and stuff like that. She also noted that she said that there are definitely families that aren't on the list because they've given up. My family, as well as others, stopped resubmitting the DDR for the full waiver for this reason. So
I want to just say thanks for that comment. That's the kind of thing that's really helpful to hear, because that's the big open question, is who's out there that we don't know about.
We've got a few people with their hands up. Patrick Reinhardt was the first. So Patrick, you should be allowed to talk. You should be able to talk now.
Good morning, everybody. Couple of things, and one of them is related to that last question. So we do hear of a number of people giving up on the being on the DDR because their needs aren't great enough to keep going to the top, so they just keep going to the bottom of the list. And so that's an issue I think that needs to be addressed on how we weight the list. There should be at some point people, if their needs aren't great, but they still have those needs, that there's an ability to still move up that list and not wait for 4.5 years. Because there's always going to be somebody with an emergency kind of in front of them. And granted, we believe totally that you need to address those. But my question is really about, in doing this, are you going to look at other potential types of waivers? I know we've talked a lot about self-directed waivers and choice waivers and other options that might be tools for people to do to get the services that they want in their community. So I'm just asking if the study will include any recommendations on that type of thing.
Patrick, thank you for the comment. I don't believe that at this time we've talked about adding waivers because the legislature's instruction was so explicit. The plan was to get rid of the wait list for the existing waiver and prevent any new ones from happening. If I'd be interested to hear ideas that you might have about how developing a new waiver could assist with that. I mean, the ISW was developed, and this was before my time here, but in part, I understand, to help relieve the pressure on the existing IDD waitlist, in part anyway.
So, Tony, I would add to that, to Patrick's comment, that I think the idea, we recognize that stakeholders want what they are calling a self-directed waiver. I think what we believe is that the resource allocation starts to step us towards that direction. Whether we add another waiver or we allow self-direction to occur after, once we have the resource allocation tools in place, that is sort of where we're at with the 5-year plan. So 5 years is what we're asked to do in this plan. 5 years to people receiving services is a very long time. Totally understand that. But 5 years for securing assessments, building the tools we need, studying it, making sure we're building the right algorithms, that takes some time. And so I think this is sort of our idea of, and we're trying to be realistic, obviously, of stepping us towards the ability to self-direct. And I saw someone else had said, would we be allowed to add a service, or would the day hab cap be allowed to be removed from the service because people could use their budget how they chose? And I think that is definitely something we would want to consider as a part of the resource allocation. And that's why these are great questions, because these are all things that will feed that conversation and how we develop it if the plan is approved to go forward.
Janet Johnson has her hand up. So Janet, you should be able to talk. You will need to unmute yourself.
Can you hear me now?
We can.
Okay, I'm from Cordova, so I'm one of those rural areas, and I have a daughter on an IDD waiver. We waited a long time, and she's currently in Anchorage, but we're one of those families that even though she was on the waiver, I know there's problems with staffing and things, but it seems like people a lot of times are looking at the rural areas, but like we almost moved to Wisconsin because they don't have a wait list. My family's there, just so you know. But the whole thing would have been easier, and you guys would save a whole lot of money if I could have just moved the family to Anchorage when it got to the point where Rose had decided she wanted to move to Anchorage, which was when she graduated. And instead of me working 3 jobs and caring for her, if I could, have one of my jobs being cared for her. I'm a family member. I wouldn't expect to be paid all the time. But when I look at the reimbursement rates for being in a group home, which Rose does love, she's in a really good setup, but we could have done more of a hybrid with day hab and things and still had her be in a family home. But it seems like that's only something available for rural places. And then nobody seems to know. Many care coordinators said, oh yeah, you can get family paid, but then nobody seems to know how to do it. Found a couple other people out there that made it happen in their family. We did get my son paid as a caregiver, but he wasn't able to afford his own place to live or anything in the amount that he was paid. But if there was, a little more pay and, where, like I said, it would have been nice if we could have moved to the city. I just think there's a lot of hybrid options out there and choices for the people that, you really are look optimistically at what you can save. And I'm sorry to repeat things, but I really would love to be in on some of the creative, resources that you're doing. And I know you want to do the really careful things and you don't want to do the sledgehammer approach, but you might have to do a little of both, because boy, there are people there that are waiting so long, and we waited so long, and it is so hard. Okay. And families I have so many health problems because we didn't have help. And so does my son, who was her caregiver. And that's silly that we're handing off care and costing more money because we have the health problems now. And we'll stop talking now. Thank you.
I want to say how wonderful it is to have families like you, Janet, on the line here with us today. That's really great feedback. We struggled with putting a presentation because we wanted to make sure that this presentation would speak to both families as well as providers, people that have been looking at this issue for years. But hearing from families directly is one of the hopes we had. So thank you for being on and giving us that feedback.
Great. Okay, thank you.
Hey,
So
Steve, can I back up for a second? I'm sorry. I just wanted to say also to Janet, when we, you know, again, this is just a plan for the 5-year plan, but we will be asking for feedback in the coming. We will have another webinar, as Tony pointed out, and would love for you to be a part of that and make sure that you're, so if you're not signed up for our listserv, hopefully you are, that's how you got informed of this, but it would be great if you signed up for our listserv just to make sure we're reaching people and that we get that participation again. It's very helpful to us.
Do you remember, can you still hear me?
Yes.
When we had Governor Murkowski,
Mhm.
well, back then was when Rose and I started coming up asking for the wait list to be decreased or eliminated. And that was a long time ago. So yeah, we're strong in this fight, and there are a lot of people that are strong in this fight. And there are some very dedicated people that want this system to succeed. So yes, thank you. And I will be involved.
Great, thanks.
And Janet, you know what I have to say to that is I have worked a long time with the Alaska legislature. And if there's one thing they know, thanks to the efforts of people like you, it's that there's a wait list and that we ought to get rid of it. And I've seen how it often takes multiple years of banging on a door for something to finally give way and a door to be opened. And I commend you for that work you've done over the years. And I commend your colleagues and the other stakeholders who have finally knocked hard enough that the legislature took this step. I mean, it's a plan. They've asked for a plan, but that's significant. And
it is.
Yeah.
Yes. It is. And excuse me, I'm getting emotional about this because Alaska is going in the right direction. I mean, I know there's money allocated for caregivers and the raise, or, you know, the raises that'll go for caregivers, and that's all really good. And also, like I said, when we said, how is there a way for like my son to get paid as a caregiver because he's in my community, you know, when Rose was back in Cordova, and nobody really knew exactly how that goes or how does that happen. And we ended up talking to a judge, and the only other people that I know that are in our situation, they talked to a judge and, you know, made it happen. But there's a lot of procedures that aren't just, you can't just go someplace and find out how to do it, how this happens. And that was the big question, was after a while, you feel like you're, you know, the term gaslighted. They say I can do it, but nobody can tell me how. And it wasn't written down. So hopefully this will help, you know, get things in order, things written down, procedures also, which, yeah, I hate to spend another minute saying paperwork, but if things are clear, you know, if people have steps they can follow, that helps also. Very clear steps. Thank you for this presentation.
thank you. So Michelle, I'm unmuting you.
All right, thank you. I'm here with a couple different hats on. Obviously, the Key Coalition of Alaska, who has brought this waitlist issue to the legislature and the department for decades, and so feel some responsibility for this meeting today and appreciate the time and effort that's going into it. Also have been in the provider world for decades as well, and as a guardian, experiencing the waitlist issue very personally for almost 6 years. And again, the weighting of how people that have natural supports and supportive families are weighted, you know, far lower. And we were told at one point to kick our friend Carrie out of our home in order that her score would increase. Of course, we would never do that. And now she does have a waiver. But families shouldn't be put in the position of we lived that in Alaska, where families had to give up their kids in order to get services, and we created a better path for families. So I think that as we look into this plan, need to think about how we can make things simpler and easier. A lot of people are on a wait list for this waiver. Perhaps eliminating the wait list looks outside of the waiver track and brings back some grant services where providers could be creative and be able to serve people in maybe group settings or group living situations where they're not having to do supported living in 15-minute increments, one staff on one person, which makes it a little bit tougher with a workforce shortage. So there might be some creativity within that, and would probably be dialogues that are coming in the future down the road to say, how can we use some granting that could potentially serve some of the folks that are maybe waiting for services now, because that's the only track that they can get onto, and serve those that have given up. Because I really appreciate Carly's comment. I know of other families who said, I'm not even going to try. I've heard of the horrors, and I'm not even going to try. And there are adults living with 80-year-old parents now that we anticipate somewhat of a tsunami of need that will be up and coming when those families can no longer care for their kids. So I'm just welcoming the conversation for the next steps. I think he has also brought some cost-saving suggestions to the table that we could still look at for coming up with additional resources for how do we find more funding for folks that we'd be happy to, re-examine. And then again, looking at our waiver plan, is there a way to make our waiver plan as a state more efficient or more expansive in the sense of using staffing resources that are not going to get any easier probably in the next 10 years. We're not going to look at suddenly, oh, now we have plenty of staff. So we're going to have to look at how we can provide services more efficiently and in different ways to meet the needs.
Great.
Yeah, thanks, Michelle. Those are great comments. The word creativity, I've written it down. That summarizes it well.
Okay. Kathy asked, have stakeholders been involved with SDS in the contractor discussions up to this point?
No, this is the first public comment that we're offering. But I would say that very much in a way, the stakeholder input that we've received over the years on the wait list has gone into informing our approaches that we presented to you today.
Well, also, we did get a lot of stakeholder feedback when we were working with the contractor on choosing an assessment tool. We also have gotten feedback along the way through the various committees and councils on resource allocation, self-direction. So it sort of helped us sort of put together this very high level plan based on what we hear from people that they want. And, we never get it 100% right. But that's why it's just a very high level plan. And this is very early in the process. And so that's the goal, is to include folks.
Jennifer Williams has her hand up, and you should be able to talk now. Jennifer, you want to unmute yourself?
Hello, thank you. Can you hear me now?
Yes, we can.
Okay. Hello, my name is Jennifer Williams, and I've been a caregiver for over 10 years. Over the years, I've worked with all sorts of people, including people who needed IDD waiver care. I love my job and I love my clients, but over the years, I've seen a lot of people go without the care they needed because they were on the wait list or on other waivers and programs that didn't cover all the care they needed. My clients deserve to have all the help they need to be able to have the same kind of life I have. A federal law says we have to take care of them. If families ask for help and these families need help, if we can't help these people the way they deserve, we have to send people to institutions. And we can't go back to that. We can take care of people better and for less money here at home. And that's great. How often do we get a chance to get a better service for less money? In this case, it's a lot less. When we don't provide the care we know people need, it falls on their families, and it's a real struggle. I watch family members who are giving everything they have to their families, and then the family member struggles to get to their own appointments or to take care of themselves really at all. And like I said, those other programs and waivers just don't offer all the care people need and deserve. For a long time, we were able to put 200 people off the list every year, and now we can only do 50. That's really hard because the last I knew, it was taking more than 4 years on average for people to get their waiver. And now the list is bigger than I can remember, over 800 people. It's heartbreaking thinking about all those people and families that are just waiting. This is so wrong. People are desperate and they just want to be able to do the same things all of us can do. Why should they wait? We need to put enough into the system to pull everyone off the list and to get the help they need. Thank you.
Great comments, Jennifer. And someone at the legislature has heard those comments, and they've asked that we address exactly what you're saying through this plan.
Awesome. Well, thank you so much for having me. I appreciate it.
And I want to make just a slight correction. It's a good correction to make. The legislature this past year, as it did the year before, said let's pull a minimum of 70 people off the wait list, not 50. Thanks to some of our flexibility in our waiver, we've been able to pull more on the order of 100 to 114 people off the wait list this past year. So anyway, that's just good news for those folks.
Okay, 100 to 114. Okay, all right. Thank you for the correction.
Okay, and Kim, you should be able to talk.
Can you hear me?
Yes, we can.
Okay, great. Thank you.
Oh, sorry. Actually, Kim, I pressed the wrong button, so that was my mistake. Can you speak?
Okay. All right. You can hear me?
Yes.
Okay. Well, thank you so much. So my name is Kim Champney, and I'm the director of the Alaska Association on Developmental Disabilities. We have approximately 50 service providers around the state who are providing services. And we are, providers would love resource allocation, some sort of resource allocation. That's been our conversation. And a lot of it is around the freedom that comes with somebody saying, wow, you get this amount, your needs are here. So let's work together to figure out how to meet your needs, like the budget being pretty well defined instead of how a support plan might describe somebody. It just really is so much more strengths-based. A few things that come to my mind that I wanted to share. I think we all can see the fiscal note, like the cost of just saying, well, we're going to have this wait list and we're going to serve them just like we've been serving people is going to be difficult. And I really appreciate what Janet said, what Michelle said, what we've been talking about, that I would encourage the plan to include the acknowledgement that we can't continue to serve people just in the same, like in the boxes that we currently have because of workforce, because of cost. And so that's where things like technology, there are people who with a little bit of technology and a way to support people differently, it would be cost effective and help people get off the wait list and start moving forward in their lives. I agree, family caregivers and probably needs to be part of the solution because of the workforce shortages. And I think there probably are other very creative ways like self-directed budgeting. I know that that is not part of what you all are directed at this moment, but if we can look at other states and see if somebody's given a pot of money where they could hire a neighbor or pay for transportation to get to work in a really flexible manner, again, that takes them off the wait list for services and is a cost-efficient way of serving them. So I wonder if part of the plan you put together that is going to educate us all and the legislator is the recognition that we have to build in flexibility if we're going to really meet the needs of everyone. And so I just wanted to share that. And thank you for your work on this.
Kim, thanks as always for your excellent counsel. These are great thoughts. Appreciate it.
Great. And Rick, I've unmuted you.
I am the person I am the president of Peer Power. Peer Power is a statewide self-advocacy organization. We help a lot of people who are on the wait list and also those that are on waivers. We like and support that you're creating a 5-year plan to end the wait list. However, you need to have a lot more self-advocacy input in this. I've heard that you're listening to providers and families and DSPs. That's great. I like that. However, you need to reach out to self-advocates themselves. We're the ones with the greatest impacts and have to deal with this. We're the ones that don't have the support. We're the ones that you really need to listen to. If we don't have the right services, we cannot live our lives. And that leads to my next point. Self-direction. By far, the majority of states have self-direction. People are a lot happier with budget authority. Where the person receiving services controls their own services. And they choose what they need to have a more happy and fulfilling life. And I have seen that also the direct support staff are a lot happier with the system. Because they're working more for that person they serve. And that person receiving services has a lot more control over their services. Peer Power would be very happy to be involved in the conversation with you all about this. So we'd like to be brought to the table on this process. A lot more.
Greg, thanks as always for your input. I really appreciate it. I'm glad you're here. This is one of the challenges we faced here in that we only learned about, of course, the the item would be in the budget in late June, and then we didn't have any plan to be able to fund the development of the plan, and that took a little time to work through with the Mental Health Trust, and then bring Steve Lutsky on board and sort of begin brainstorming. So we are, as it goes, really trying hard to get this done over the next few months left that are to us now. But we do intend to hold more input opportunities for input. We appreciate you spreading the word among your colleagues and peer power and elsewhere, because we do value your input and do want you to be part of the conversation as we go. Anything else anybody would like to add to Rick's comments?
This is Lynn. I would say thank you, Rick, as well. I just want to sort of make it clear we're not trying to value anyone's comments or feedback over other people's comments or feedback. Everybody brings a perspective, including the state, and what we're supposed to do from the federal level. So we encourage feedback, and this is really the first presentation we've done. We haven't tried to exclude anyone. So one of our other challenges sometimes is when we put things out on a listserv, we want everyone to see it on the listserv. We try to put words out to people, but we can try to be more thoughtful about that. But I would encourage people to join our listserv if they aren't already on it, because that is really our true way of communicating out to the world. Hey, we're doing this, or we need input. Jetta, were you going to say something?
And if you need instruction on how to get on that, Andrew, could you show our SDS main webpage? We'll just tell people right now who aren't on how to get on. It is, the messages often are more for providers, and we're very appreciative that the Governor's Council and other advocacy groups snowball, that's not a technical term, but share what goes out in a listserv with their recipient communities. So on the right-hand nav bar, the gray box that is on the right there, scroll all the way down to the very bottom, and you will see right there, sign up for e-alerts. And if you click on that, which you can do right now, then you will see that you can enter your email address right there. Know that this is a two-step process so that somebody can't get signed up in a nefarious way by somebody else. So when you enter that email, you will get an email that says you need to do something or take action and do that other task, and then you will be successfully added. Sometimes those emails that come to you go to your spam filter. So after you've filled out your email on this screen, you should get that follow-up email fairly quickly. If you don't, check your spam filters. In order to complete the process, you need to take action on that second email. I hope that's clear. And I think lots of folks in the recipient world can help you with that if you bomb out.
Thanks, Jeff.
Okay. And Heidi Young asked, what does the state spend annually on updating every person's DDRR? Could the state realize cost savings on using the new tool with less annual testing?
That's a great question, I think. What is it that we spend on managing the DDR that we ought to consider savings when we eliminate the DDRR? So I don't have any firm figures on how we could go about thinking about how much we do spend on that. But Heather Cord, I see, who manages the DDR, is on the call. Heather, do you have any comment to Heidi's question?
Well, it's twofold. So when I read it, I sort of thought about my time in scoring all of the new DDRRs, but then there's also the other side in terms of the DDRC reps who, help families to submit those forms. So it's not currently a data point that we track in terms of the total hours, but it is interesting to sort of think about. So I appreciate the comment.
Okay, and kind of in a related question, Anna was asking what would happen to the DDRC centers and how much would the software cost and what would be for each center person or SDS?
That's a great question, Anna. We will be trying to build in the software cost into our estimates for what a resource allocation approach would take. I don't believe there would be any significant change to the work that we would ask of the DDRCs, but I'll ask the people closer to that work at Pam and Heather and Lynn if they have any thoughts.
I would offer that the DDRCs would still have a role. There's a lot of different tasks that they help families with outside of just filling out the DDRR form. That's just one aspect of their job. So I wouldn't see that position going away in any means. Pam?
No, yeah, I would agree with that. I believe the cost of the software, going back to that last question, the InterEye software itself is free, but we would need to look at how that corresponds with our current system to make sure that they talk to each other.
Okay, and an anonymous attendee was touching on the workforce issue and the challenges within that and they added another wrinkle to it. They said a possible unintended consequence might be that people with simpler needs will be supported first versus people with more complex needs.
That's a very good question. And this is Lynn. I would say, you know, it could be how we develop the plan, how we might address that. So that is something that we also consider, because it is easier to serve someone that's less complex. And we know that sometimes that's all providers can handle, or they choose that because they have the staffing resources to meet that person's needs versus someone that is more complex. And so with resource allocation, if you're building in a higher level need, that may come into play, where we also would build a higher level acuity rate for someone. But that is a little bit farther down the road. Again, it takes a long time to develop a resource allocation tool and the assessments that go with that, because you want to make sure that everything is done thoughtfully. And along with the lines of self-direction, to be able to even develop a budget for someone, we really need to have a resource allocation tool available to us. You know, in line with sort of adding services to our existing waivers, that always comes with a cost because people want that service. So that is one thing about resource allocation. If people, as Kim mentioned, if people have a budget, then we could be perhaps more flexible within that budget for folks. And I think that's what we're all sort of saying, the same thing in different ways. We're needing to build some of those tools in place to get us to self-direction and the flexibility that I think people want. And also to be able to serve some of those complex individuals that we have a difficulty serving right now, I think, as a community as a whole. But thanks for the question.
Okay, and an anonymous attendee asked, is there any advantage to looking at a managed care entity to assist with the management of the waiting list as well as the growing provider capacity?
Well, you know, Alaska is a fee-for-service state, so that sounds like a pretty significant hurdle to try and meet. A managed care entity, and I'm a little confused by the question because we want to eliminate the wait list, so we don't want to have a wait list to manage. I do know that some people, some states that have adopted a resource allocation approach use fiscal agents to help people. Maybe this is further down the road, to help people manage their budgets and their resource allocation. Maybe that's what the questioner is asking about. So that would be something that we would be looking at.
Okay, and Sandra was asking if I could speak to what Wisconsin did And I'm presuming she's talking about the elimination of the wait list for some of the IDD folks when they started the family care program. Wisconsin started family care in conjunction with the ADRCs. Family care was a managed care program that just capped the cost for the overall IDD budget. So they would set by regions, like here's the amount that they have allocated for the IDD for each region to then be able to manage and be able to figure out how to serve individuals. I haven't looked at Wisconsin recently to see if they've been able to maintain that or other changes that they needed to do to kind of be able to keep the costs under control. But certainly if this effort does look forward, Wisconsin would be one of the states that we would be looking for guidance.
Steve, let me ask you, the big news a couple of months ago was that Oklahoma, I think it was, had eliminated its wait list. Do you have any background as to how they went about doing that?
Yeah, Oklahoma's isn't eradicating the wait list. It's a one-time thing where they are serving everybody on the wait list as of May of 2022. So it's a fixed cost, and that will not stop them from creating a new wait list if additional resources are not allocated in the future. So what you guys are proposing is more challenging. It would be really relatively easy to develop a fiscal impact statement and a plan to just serve the people that are currently on the wait list. The challenge is for those other people that currently are not on the wait list that have been, just because of the paperwork or the other challenges are not on there, to figure out what is the impact of trying to serve those individuals.
Thank you.
Okay, and Emily Ice was saying that previously the IAT was used to support a recipient's under 21's access to other IDD supports such as DayHab by assisting in reducing more intensive behavior-related challenges. This was sunsetted in 2018, 2019 for children, and only children with an autism diagnosis have access to comparable behavioral services under EPSDT. Is there an opportunity to reconsider sunsetting that as an option? This might even open up some options for individuals who experience behavioral challenges.
Thanks for that question, Emily. The change there to IAT predates me a little bit. I'm just wondering if any of the folks from SDS can speak to that history at all.
I can take the one unless you want to, Lynn.
Yeah, go ahead. Go ahead. I see you typing in answers. So.
I was typing, but that's okay. So currently, the Division of Behavioral Health oversees applied behavior analysis, which falls under UPSTAT. And the change was made because it's required by the federal government that through UPSTAT, states provide certain services related to health conditions. And so the applied behavioral analysis services fall under that category. So we do still, under the home and community-based waiver, we do still have intensive active treatment as a service that is available for individuals over the age of 21 when they do have a new immediate need. And there's a couple of different things that qualify for that. A person can request that service and have certain needs met that may sort of fall under the behavioral health, mental health realm. And some of those services may be ABA-esque, but specific applied behavior analysis falls under the Division of Behavioral Health under UPSTAT.
Thanks, Heather.
Go
ahead.
Oh, I was just going to say, and the federal government told us it has to be done under UPSTAT. It was considered basically a duplication to do it under the waivers as well. But that was just a little add-on I was going to say to that. Go ahead, Steve.
And Heidi Young had her hand up, and Heidi, you should be able to speak now.
Perfect. I just want to say thank you all for this meeting today. I really appreciate it. And I know the people that I help serve appreciate it as well. My question was about this new inter-RIA. Will it eliminate like the redundancy of the ICAP? For example, when someone has a Down syndrome diagnosis and they've been determined to meet the waiver, will it really be necessary to go through that full assessment process every year? Because it does seem, frankly, it's frustrating to families, and it seems like a waste of resources.
Lynn, what do you know about the NRI and how that would work?
Well, that's a little bit of a complicated question because we do have to determine level of care every single year. That's a federal mandate. And so how we do that is a little bit flexible, but not completely. So with the INTERI, I think there are probably some ways that we could look at that, Heidi, to figure out if all parts of it would have to be done every year. But if you're using it for planning and it feeds into a resource allocation, you would want to know if there were changes. So it's a much different assessment than the ICAP is. I will say that. And so we would probably have to cross that bridge, but it's good to note it and to take it into consideration, Heidi. So thanks for the comment.
And one thing about the NRI tools is that they are designed to be minimum data sets. And by that, they mean that they're trying to just collect the absolute bare minimum of information that they think is necessary to be able to plan and understand the populations that they're serving. Okay, and Rick has his, oh, you're welcome. Rick has his hand up. So Rick, I've unmuted you.
Sorry, we never took it down.
Okay. I've been
Rick's waving to everyone. We have 6 minutes left, just
6
as
minutes
a note
left,
of
and we have
time.
no
Yeah.
open questions and nobody who has their hands raised.
Give everybody a couple seconds, couple more minutes.
I just want to say what great input this has been, and that we've recorded this, and that the input, I've heard great comments and great creative ideas. I can already see that one of the challenges we're going to face is how to cover all the possible elements that have been proposed into a plan that is still ready by December 20th. That's kind of the big challenge that we have before us. But great ideas all around, and I'm eager to talk about these and see what we can work in as we go.
Okay. And Anna was asking if you could provide resources for the NRI tool. I'm going to put in the chat the NRI website. So you should be able to log in there, and they have a lot of information about the tool. There was one portion of a question earlier that somebody was asking if the slides will be distributed.
What do you think, SDS? Could we make the recording of this presentation available and alert people to it through an e-alert?
Mm-hmm.
Yeah,
I think so. Yeah.
So
And the
it'll be
slides
available that way.
themselves would be embedded in that.
Yeah, let's
Obviously.
do it.
And that would come out, just so folks know, usually we take the recording, we send it to our training unit, and Cara puts it into a YouTube channel. So it would become a YouTube video.
So that may take us a couple of days to get done,
Correct. Mhm.
depending on what else she's got on her plate right now.
Correct.
And Benjamin just asked, as the resource allocation model seems to be the path forward, my question is, the individuals that require some of the highest levels of support are sent out of state to residential treatment facilities. Is SDS planning on factoring in plans to expand Alaska's infrastructure to address some of the needs in the resource allocation model?
That's a great question. Benjamin, you may know that that was a topic that got a lot of discussion at the Improving Lives conference that the Mental Health Trust put on a few weeks ago. All I can tell you is that provider capacity issue from all ends of the spectrum is going to be something that we're going to have to at least devote some discussion to in the plan that the legislature receives.
And I think it, just as I'm thinking of this, it's not really pertaining to that, but wanted to thank the Mental Health Trust Authority for supporting us in our earlier endeavors on Interi, and hopefully going forward, they will as well. But they have been very thoughtful in how, in some of our engagement that we have, the work we've done to sort of research the Interi tool has been funded by the trust. So thank you for that.
And Janet Johnson has her hand up. So
I just wanted to say one more thing. So right now, I mean, as we're making the changes with because our caregivers are getting a raise, and we're, obviously a lot of businesses are coming together and, trying to figure out how to deal with that crisis. And you're making this plan. I mean, we're trying to incorporate things that are in process also to get this plan all coming up together. I mean, you said you're looking at what Wisconsin's doing or what other states are doing. So this looks like, I mean, it sounds like there's a lot of things going on in Alaska. Are you going to be able to incorporate, some of the things that are evolving with this plan? Like Pure Power, let's say, they've gotten a lot stronger. They've used technology to get themselves a lot stronger and to be able to be there to ask questions and to answer questions, and also with their families that are far away, and you said there's training programs. So I mean, with developing this, you're actually looking at the stuff that, even though it's new and just starting, are you trying to incorporate some of those things into that plan for ending the wait list? I'm just saying, because it seems like there's a lot of approaches that maybe aren't set up in Alaska quite yet, that are all working together. I mean, is that part of the plan too, that you're not just, hey, this is what we can do, but we actually, have to develop some certain, we might need money or resources to develop these programs to make this keep going? I suppose it is right that you would be doing that. I just don't want to, I've just seen a lot of movement as a family member and a caregiver who's been watching this a lot. And it seems like you have a lot of things right on the edge of, training. We've gone places where caregivers hadn't had any training. I mean, even the simplest training to help somebody eat a spoonful of applesauce. And so, are you looking at those things as, oh, this just got developed and let's put this in the plan? Okay, I'm rambling. I'm sorry. But I mean, obviously you're trying to, but that is part of it, right? That it's sort of the legislature's saying, not only they were trying to grab more people off the list, but, they're trying to help the caregiver thing. I mean, so you're kind of looking at not revamping the whole system, but kind of, right?
Right. No,
So-
Janet, what I hear you saying is that there are an awful lot of moving parts here in Alaska.
And like you said, the technology alone, the way people have used the technology since COVID, I mean, this is the time to take it and run. I mean, we had no connection or input from a lot of people, and now we have. And I'm just talking about me as getting support as a caregiver who had zero, not even family members that could take my child for a night. Now, one night. So, do you know what I mean? There's so many exciting things happening. So I'm hoping that you really look at those with, eye-opening, these are big things, such as, I'm just using Pure Power because I was astonished to see the 5-year progress, and then to see what people were saying they needed, and some of them were very little things that might be able to be implemented with just some basic training and not a $1 million budget, but that could get into the system. So you really have more resources than you had even 5 years ago. Anyways, I'm sorry, but I just really hope that you're looking at some of this new stuff that's come about as, giving them a chance, not saying we can't look at this because it's 5 years away from being fully implemented, or we haven't watched it long enough, because like my daughter, her needs change often. And I'm just, like I said, excited what's happening. And I'm sorry, I raised my hand again, but
That's okay.
No.
thank you for letting me speak, because this is exciting. We might actually do this. We might actually get the waiting list to be gone and the people that are actually using the waivers to really be served better. So thank you for all your hard work
No,
in all
thank you.
these things.
Yeah, no, I
Okay.
hope I represented what you were saying by summarizing and saying that there's a lot of moving parts. We have a lot to try and incorporate into the plan. We got more today. And the challenge will be providing as comprehensive a plan as we can, while also still making it something that the legislature will actually read and want to act upon. So so that's the challenge before us, and we want to engage as many of you as we can along the way.
And Mr.
Well, and-
Letsky, are you going to like smile or something, or say you're hopeful, or give the look like I'm not saying anything yet?
One, we do not want to make the plan to be overly complex at this time, because I think if we're going to be presenting that to the legislature, that they'll just kind of get overwhelmed in the details of it. Like, what we want to have in the plan is crafting out the major directions of what we're seeing. So like including the resource allocation. Won't be establishing all of the details and all of the different components of that. That's the work that will be done once the plan is implemented. And we are hearing from you that today we heard that you're very concerned about provider capacity. You're very concerned about the ability to have it have more self-direction and more control. And that's kind of seems to be a key component to addressing provider capacity. So we'll look at the high level of in the plan, building the more specific components of that included. So the plan would be, a lot of the plan will be to plan to build out some of that more developed infrastructure, but this plan went detail, like whether it's going to have peer power or the specific interventions or the specific components that would be included.
Right. I was going to add to that, Steve, to summarize the same things that you just did, that this isn't a promise. At this point, we are developing a plan for the legislature. It's a relatively new legislature coming in. So it's important that we might not make it too complex. We'll be explaining a lot of what our services even are. And so it's really important that we hear from all of you, especially during any kind of forward progress and developing a sort of what we would call an implementation plan. If it's approved, if it's funded, if there are a lot of ifs. So it's not a promise of things to come. But I think that's why it's so important, and Tony has reiterated this again and again throughout this meeting, that all of you are on the phone and we've heard your advocacy loud and clear. And I think it's important to keep that message moving forward as we develop this high level plan for the legislature. And I think we're out of time.
Yeah, we're well out of time.
Thank
Thanks,
you.
Lynn. Those are great comments. I would just echo that. Lynn, you stated it really well. We are, I heard great comments. If there was anything coming out of this that concerns you, please remember to email Steve. Steve, maybe you could post your email in the chat real fast again. And I'll let us wind up. I know we're over time.
Yep, and it's just at idd@hcbs.info.
Okay, so stay tuned for our next get together and have a good afternoon.
Thanks, everyone.
Thank you. Bye.